So, here is our agenda for today. We'll start with rectal prolapse core concepts and surgery, touch upon solitary rectal ulcer syndrome, and then shift gears to pediatric anorectal malformations, covering the symptoms, classifications, and staged management.
All right, Section 1, Rectal Prolapse, Core Concepts, focusing on the anatomical breakdown. We're starting our first pathway right here.
First things first, we need to define rectal prolapse immediately because the treatment hinges entirely on the specific tissue layers involved. Rectal prolapse isn't just one single event. It's broadly categorized into either a partial or a complete thickness prolapse. Understanding the difference between these two forms is literally the bedrock of clinical management. This is a vital core dichotomy. Partial prolapse involves only the mucosal layer. It's much more common in children, often driven by an incomplete sacral curve. If it's their very first episode, you simply manage it with digital repositioning. If it keeps coming back, Thierschweiring or sclerotherapy can be used. Now contrast that with complete prolapse. This is a full thickness prolapse of all the layers. It strikes adults, usually stemming from a weak pelvic floor. And management? Well, that is entirely surgical, requiring either perineal or abdominal procedures.
Now, quick pause. Before we talk about the surgery for complete prolapse, we absolutely must address a vital diagnostic question for our pediatric patients. Because occasionally, children do present with what looks like a full mass. So how do you distinguish a true complete rectal prolapse from an intestiception, where the intestine kind of telescopes in on itself?
It literally comes down to a simple, elegant clinical test during the physical exam. If you examine the patient and your finger can pass between the wall of the rectum and the protruding mass, you're looking at an intussusception. But if your finger cannot pass because the tissue is continuous with the anal verge, then that is a true rectal prolapse. It's a massive red flag to look out for, and it changes your entire management pathway.
Moving right along, Section 2, Surgical Management of Complete Prolapse, focusing on our geographic approaches. Let's talk about how we actually fix it.
So we essentially pit the two surgical approaches against each other, and it's all about trade-offs based on the patient's overall fitness. Perineal procedures, which are performed from below, are way easier to tolerate and have fewer operative complications, but they carry a very high recurrence rate. Because of that, we reserve these for frail, elderly patients with other comorbidities. Abdominal procedures, on the flip side, are much more difficult with higher immediate operative risks. However, they boast a significantly lower recurrence rate. You absolutely want to use the abdominal approach for your young, fit patients who can handle the surgery and need a permanent fix.
Let's put some names to these procedures. For frail patients getting perineal work, we might use Thierschweiring, which is essentially a purse string suture to keep things in place, or a Delorme repair, which plicates the mucosa. There's also the Altamir repair, basically a perineal rectosigmoidectomy, where the redundant colon is excised. Meanwhile, our fit patients getting abdominal procedures will likely receive a rectopexy, where mesh securely anchors the rectum to the sacrum, common ones being the Wells and Ribstein repairs. Or they might get a Frankman-Goldberg, which is a resection rectopexy.
But you know, no surgery is without risk, and postoperative monitoring is absolutely key here. Constipation is by far the most common complication we see. We also have to keep an eye out for hemorrhage and recurrence. Most critically, though, pelvic nerve injury is a major risk. In males, this can mean retrograde ejaculation or bladder dysfunction, and in females, it can cause erosion leading to a vaginal fistula.
All right, let's pivot a bit. Section 3, Solitary Rectal Ulcer Syndrome. This is a localized condition that often acts as the starting point for the prolapse we just discussed. Solitary rectal ulcer syndrome, or SRUS, is highly specific. It presents geographically right there in the anterior wall of the rectum, usually located exactly 3 to 10 centimeters from the anal verge. So why do we care about this specific ulcer? Well, because it acts as a major precursor and starting point for structural prolapse.
Now, listen up, because this is a massive clinical red flag. When you see this ulcer, you cannot just assume it's SRUS. You absolutely must perform a biopsy to rule out cancer. What you're looking for histopathologically to confirm SRUS is a very specific finding: fibromuscular obliteration of the lamina propria. Once you see that, you can breathe a sigh of relief knowing it isn't malignant.
Okay, cancer is properly ruled out. Now what? Management relies on the STAR procedure. That stands for Stapled Transanal Rectal Resection of Intussusception. It is a highly effective way to resect the involved problematic tissue right at the source.
Shifting gears entirely now. Section 4, Anorectal Malformations and Symptoms. Let's see how this builds into our second major clinical pathway for today:
congenital pediatric anomalies.
So, anorectal malformations are characterized by the absence of a normal anal opening. But the golden rule here is that these malformations rarely happen in isolation. You absolutely must look for the associated issues using the VACTRL mnemonic. That's vertebral defects, anorectal malformations, cardiac abnormalities, tracheoesophageal fistulas, renal abnormalities, and limb abnormalities. Basically, if a child has an anorectal issue, you immediately initiate a workup to check the spine, the heart, the kidneys, and the limbs.
Because of these abnormal anatomical connections, the clinical symptoms of these malformations present very sharply along biological sex lines. In males, the rectum often connects to the urethra. Because of this, you'll actually see fecal matter pass during urination, and they'll heavily feature recurrent urinary tract infections. In females, the anatomy tends to connect differently. The anus might be abnormally close to the vagina, or you'll frequently see rectovaginal or rectovestibular fistulas.
Which brings us to Section 5, investigating and classifying anomalies. Before we can operate on these tiny patients, we have to perfectly map the pediatric pelvis.
Obviously, the absolute gold standard investigation to delineate this anatomy is an MRI. But there's another fascinating, classic diagnostic tool called the invertogram. This requires immense patience. You actually have to wait exactly 24 hours after birth. Why? So swallowed gas has enough time to travel all the way down the GI tract to the terminal rectum. You place a physical metallic coin on the skin at the proposed site of the anus, hold the baby inverted, and take an X-ray. The gas bubble floats up to the blind end of the rectum, and it provides a brilliant visual contrast against that coin on the outside.
And the magic number you're looking for? 2 centimeters. You measure the gap between the metallic coin and the gas shadow. If the distance is less than 2 centimeters, it indicates a low malformation. If it's over 2 centimeters, it dictates that you are dealing with a high malformation. That single number dictates the entire surgical future of the child.
It's actually kind of amazing how the specific type of fistula flawlessly categorizes the anomaly's severity across males and females. For high-level anomalies, males often experience anorectal agenesis, while females see rectovaginal fistulas. Conversely, for low anomalies, males rarely present with pure low anomalies, while females commonly present with anal atresia. Mapping these variations is exactly how we build our surgical plan.
Finally, Section 6, Staged Management of Malformations. Let's translate our classifications into action.
So, remember that 2-centimeter rule? If it's a low anomaly, we can usually manage it directly with definitive surgery right out of the gate. High anomalies, however, are far more complex and demand a staged approach to protect the patient. Step 1 is almost always a diverting colostomy. We have to safely route stool away from the blind pouch and the delicate urinary or vaginal connections. Then, once the child has grown and is stable, we move to Step 2. Definitive anatomical reconstruction. A classic example of this is the PSARP, or posterior sagittal anorectoplasty, to carefully pull the bowel through the sphincter complex and create a functional anal canal.
Wow, we've covered a ton of ground today, from the frail adult with a complete prolapse to the newborn with a high malformation. And whether we're talking about adults or infants, surgery in the pelvis carries immense risk. So I want to leave you with this final thought. As our surgical techniques for anorectal reconstruction evolve, how might we better protect those microscopic, delicate pelvic nerve structures to ensure not just anatomical survival, but long-term functional quality of life? Keep that question in mind. I really hope this explainer has provided you with a clear, structured mastery of these complex conditions. Keep learning, and I'll catch you in the next explainer.